child usually occurs as a result of acute toxoplasmosis in pregnancy. So a mother who was not previously infected with toxoplasmosis acquires the organism, and the rate of toxoplasmosis in the unborn child is about 1.5 cases per 1,000 live births. And these outcomes are more severe the earlier the mother gets. So the earlier the stage of pregnancy, the more severe the manifestations are likely to be. The classic triad is CHI, chorioretinitis, hydrocephalus, and intracranial calcifications, and can manifest in the neonate with seizures, mental retardation, macrocephaly, or can even result in fetal loss and neonatal death. In terms of ocular toxoplasmosis, so that's toxoplasmosis of the eye, that can occur in anyone regardless of HIV status, even someone who's HIV negative. It's the commonest cause of what's called posterior uveitis. Active lesions have what's called a headlighting fog. That's the picture to the upper right. Headlighting fog appearance usually due to both the impact of the organism infecting the back of the eye, as well as the impact of the immune system fighting that organism. And once the lesion has settled, you typically get this sort of chorioretinal scar in the posterior pole close to the macula, which is why in persons with toxoplasmosis of the eye, they tend to get fairly devastating vision loss. And in non-HIV AIDS persons who are suffering from immunocompromise, so for example, someone who's on immunosuppressive medication for whatever reason, solid organ transplantation and so on, it can occur either as a result of acute infection or reactivation of latent disease. In about half of persons who develop clinical manifestations, you get CNS infections, so headache, seizures, automental status, focal neurological deficits. Pneumonia has been reported with signs and symptoms closely resembling pneumocystis jirovecii pneumonia, fever, non-productive cough, shortness of breath, diffuse pulmonary infiltrates, and may also present with mild flu-like illness as an immunocompetent patient. And in the person living with HIV, toxoplasmosis almost always occurs in the context of reactivation of latent disease, which is why one of these things we tend to request standard on the first time we enroll someone into care is the toxoplasma antibody to document whether or not they have been exposed to toxoplasmosis in the past. A CD4 count less than 100 and toxoplasma seropositivity results in a 33% of 1 in 3 chance of reactivation on an annual basis in someone with HIV. In the pre-ART era, about a quarter to just under a half of all persons who were seropositive for toxoplasma would eventually develop toxoplasma encephalitis. So the commonest manifestation is usually as toxoplasma encephalitis or cerebral toxoplasmosis. It's a subacute onset over the course of usually several weeks with focal neurological signs, headache, automental status, seizures, variable neck stiffness, and neuropsychiatric manifestations. And usually the manifestations would depend on wherever the lesion or lesions are. It's not included there, but there was a patient of ours some years ago who actually had both cerebral and spinal tuberculosis at the same time. So he had a hemiparesis from the cerebral disease and a paraparesis with bladder atony as a result of a spinal disease, and he actually responded marvelously to treatment. And we also present as a fulminant diffuse encephalitis, so essentially the entire brain is under attack by this organism without any evidence of focal involvement. Extracerebral disease may occur with or without CNS disease. So disease of the eye, the lung, are the most common, but any system can be involved in, most commonly after those two, heart and hepatobiliary, so for example, the pancreas or the liver. Ocular disease is characterized by blurring of vision, visual field deficits, ocular pain, and photophobia. Pulmonary disease, as said before, is almost impossible to distinguish clinically from PCP. And I remember some years ago, at the Rescue Center, they had mentioned that they had all the cases that they were previously treating as pneumocystis. Quite a few of those cases, when they did more sophisticated tests, came back as pulmonary toxoplasmosis. It just happened that they responded to the same medication, so the assumption was it was pneumocystis. but would typically occur in persons with HIV with profound immunosuppression, CD4 counts less than 50. There's also a disseminated form of toxoplasmosis that presents with a sepsis-like syndrome, hypertension, disseminated intravascular coagulation, elevated LDH, and pulmonary infiltrates. Difficult to distinguish from other forms of disseminated opportunistic infections, for example, tuberculosis or histoplasmosis. In terms of imaging for CNS toxoplasmosis, and the rest of the talk is going to focus more on CNS disease. So CT imaging in about 70 to 80% of persons affected with toxoplasma encephalitis would have multiple ring-enhancing lesions with a predilection to basal ganglia, thalamus, corticomedullary junction, essentially the well-vascularized areas of the brain. But that being said, a solitary lesion does not exclude the diagnosis. The size may be variable from less than a centimeter to more than 3 centimeters, and they may be associated with vasogenic edema and mass effect. But the CT may be normal or show cerebral atrophy with diffuse encephalitic forms of disease. So a solitary lesion does not exclude it. A non-enhancing lesion does not exclude the diagnosis, and a normal-looking CT does not exclude the diagnosis. So essentially, any person with HIV with a low CD4 count presenting with symptoms related to the central nervous system, toxoplasmosis must always be part of the differential diagnosis. Magnetic resonance imaging is more sensitive than CT. Usually shows high signal abnormalities on T2 weighted studies, rim enhancement with surrounding edema on T1 weighted contrast enhanced images. But the radiological differential diagnosis tends to be one of primary brain lymphoma, but also any abscess of the brain, so whether it's pyogenic, tuberculous, even metastasis can also look similarly on imaging of the brain. And in those cases, a brain biopsy would be required to diagnose suspected cases. There are other modalities, for example, PET scanning, that are useful in differentiating between primary brain lymphoma and toxoplasmosis of the brain. So, excuse me. I think I've been, I'm not quite sure this happened. Apologies, this technology is punishing me today. I'm not quite sure for what. Right. Okay. So the following are supposed to be, right, some images from cerebral toxoplasmosis. So the image to your left is MRI brain from somebody with cerebral toxoplasmosis, demonstrating the typical, multiple bilateral lesions with that rim of enhancement around a hypodense core. To the right is the CT brain pre and post IV contrast in someone with cerebral toxoplasmosis. The pre-contrast lesion is to the left, the post-contrast to the right. So it's just sort of, I'm not sure if the mouse will cooperate. So this dark area here, and so you see the asymmetry where this ventricle is larger than this one, so it's sort of pushed off to one side. And when you inject the contrast, you see this ring enhancing lesion appears. That's classic of cerebral toxoplasmosis, but noticeably it's a solitary lesion, right? And this was toxoplasmosis. And just for the purposes of illustration, this is another case of somebody who had diagnosed cerebral toxoplasmosis, again, pre and post contrast, but you notice that there is no difference in terms of contrast enhancement from one to the other. So this would be reported as, hypointense lesion, no enhancement. So unless the radiologist is astute and he gets a full history and is aware of the different ways that neurotoxoplasmosis may present, it will not be entertained with the diagnosis, and it might be reported as infarcts or vasogenic edema or something like that. So in terms of other methods of making the diagnosis, it's diagnosis usually made empirically and clinically based on clinical findings, radiological findings, plus evidence of response to specific anti-toxoplasmosis therapy. A positive IgM for toxoplasmosis is suggestive, negative IgG or IgM has a high negative predictive value, but there have been documented cases of persons with toxoplasmosis and negative antibody studies. So again, that doesn't belong to diagnosis. Lumbar puncture is a bit non-specific, so you get a mild lymphocytic pleocytosis, mildly increased protein, normal or mildly increased glucose. We can do PCR on the CSF for toxoplasmosis. It's very specific, but sort of in high to middle sensitivity. Brain biopsy is not routinely performed. It should be reserved for individuals in whom either there's a strong suspicion that the lesion is on imaging is not toxoplasmosis, or someone who you are treating empirically for toxoplasmosis and they're not responding after, let's say, 10 to 14 days. So this is all, the following slides are all drawn from the DHHS guidelines, the American guidelines with respect to how we manage CNS toxoplasmosis. So they tend to prefer a regimen of pyrimethamine and sulfasalazine, and the multiple doses based on weight, either 200 milligrams as a start dose, followed by, if you're over 60 kilograms, 50 milligrams, under 60 kilograms, sorry, you get 50 milligrams of pyrimethamine and 1,000 milligrams of sulfasalazine every 6 hours, along with folinic acid, which unfortunately we haven't had in a very long time in Trinidad. And if you're over 60 kilograms, give a higher dose of both drugs. Alternatively, we could give pyrimethamine, clindamycin, trimethoprim, sulfamethoxazole, which we know as sexual or Bactrim, which is what we tend to use in Trinidad very, very heavily. They have multiple randomized controlled trials that demonstrate you get equivalent outcomes between all three regimens. If the person is allergic to Cetra and pyrimethamine is not available, desensitization is recommended, but they recommend giving a Tobago in the meantime, which unfortunately I've never seen in Trinidad. So the total duration of treatment for acute infection is at least 6 weeks. Longer duration of treatment can be given if there's extensive disease or if the response is incomplete after 6 weeks. And a lot of us have experienced sometimes of persons with toxoplasmosis being on medication for many, many months, because when with repeated CT scans, there's still evidence of REM enhancement and vasogenic edema that is still persistent. So after completion of acute therapy, all patients should be continued on chronic maintenance therapy or which was secondary prophylaxis. And steroids should not be given routinely unless there is evidence of mass effect, for example, midline shift, as was shown in one of the previous CT scans. And it should be discontinued as soon as clinically feasible. And anticonvulsants should not be given except in the patient has a history of seizures. It should not be given to prevent seizures. In terms of when ART is initiated, there are no hard and fast guidelines, but the recommendation is within 2 or 3 weeks, because iris with CNS toxoplasmosis is fairly rare, less than 5% in one report. And if it does occur, it can be managed with steroids. In terms of secondary prophylaxis, again, the American guidelines reference pyrimethamine and sulfadiazine, or alternatively pyrimethamine clindamycin. We would use trimethoprim sulfamethoxazole 1 tablet once a day, 2 tablets once a day, or 1 double strength twice a day. Various other regimens, including a Tobago and pyrimethamine, are also available. And one can discontinue secondary prophylaxis if after completing initial therapy and secondary prophylaxis and having started ART, the patient has managed to sustain a CD4 count over 200 for at least 6 months in response to ART and has viral suppression. In terms of primary prophylaxis, now this is someone who is toxoplasma IgG positive with a CD4 count less than 100. That is the indication. It's either sulfamethoxazole 1 double strength tablet a day or 2 single strength. Alternatively, you can give a double strength tablet 3 times weekly or a single strength tablet daily. In persons again who are allergic receptor desensitization is recommended. Alternative regimens, dapsone plus pyrimethamine, dapsone at various doses, tobacco plus pyrimethamine, along with folinic acid. It is notable that all the regimens that are given for primary prophylaxis and secondary prophylaxis of toxoplasmosis will also work against pneumocystis. The indication for discontinuing primary prophylaxis is similar. The CD4 count would have to be over 200 for at least 3 months in response to antiviral therapy, and as well the person should be virally suppressed. One can consider discontinuing primary prophylaxis in some of our persons who are experiencing immunologic failure in ART, where the CD4 count doesn't quite get above 200, but they have managed to sustain viral suppression to undetectable levels for at least 3 to 6 months. And in any person whose CD4 count drops below 100 to 200 cells, especially if they're not virus suppressed, they should restart primary prophylaxis for toxoplasmosis. So, I think this is the last slide. How do we counsel patients with respect to how do you avoid getting toxoplasma infection in the first place? So, avoid eating raw meat, unpasteurized milk, uncooked eggs, oysters, which is a big favorite in Trinidad, clams and mussels. And all this sounds very familiar during the time of COVID. Wash your hands, especially after touching raw meat. Wear gloves when gardening and handling salt, and wash hands thereafter. Wash fruits and vegetables before consumption. Avoid contact with cat feces. But they found that pregnant women and persons with HIV who have cats are not at increased risk for toxoplasmosis compared to persons who do not have cats, which is interesting. So that is the presentation. Thank you very much. And let's open the floor to any questions if there are any. Welcome, Dr. Kumar. Good to see you.
Yeah.
Question?
If there are no questions, maybe we could get right into today's case.
Well, like Dr. Boyce said, we rely quite a bit on repeat CT scans to determine whether people have the cerebral toxoplasmosis has resolved. But due to the unavailability of CT scans for a number of patients, you encounter patients who've been on treatment for a year or even more. Clinically, they have improved substantially, but you don't have a repeat CT scan. Yet the literature indicates that most of the times after 6 weeks, most of the people's CNS toxo have resolved. Is there any room where you can use clinical judgment to stop treatment within a shorter time rather than subjecting people to a lot of medications for so long?
Well, but I'll take a quick stab at it. So, I mean, if CT scans are available, I would tend to, given that we've had experiences in the past with a person with very slow to resolve lesions, I would tend to err on the side of caution rather than risk recurrence of disease, especially if the CD4 count is still less than 200, which will be most of the cases that we still continue on therapy. Because if the CD4 count is above 200, pretty much you've managed to reconstitute your immune system. So I would be more comfortable. If CD scans are just absolutely not available, then I might go that way. But that being said, I have experience of someone who had these persistent ring-enhancing lesions, and it turned out they turned to be cryptococcus. And sort of after that experience, I tend to be very, very careful to make sure that we see the lesions, even if it takes a long time, gradually disappearing before I withdraw treatment.
Okay, thank you.
All right. Let me see. All right, so if there are no other questions or comments, we'll just go straight into the case.